Good morning.
Good morning.
Good morning.
Really happy to be here to talk to you about a topic that's very dear to my heart, and that is looking at health equity and HIV. So we're shifting from the talk that we just had now to focus a little bit on the data from a national level, and I do have some slides that will talk about the data from your area as well, and give you some idea of some of the things I think you could do as legislators. So I want to give you just a brief overview of the presentation. I'm going to talk a little bit about the epi of HIV to give you a background on the epidemiology, so we're speaking from the same frame. And then to talk more importantly about the contributing factors. I think if you present the data without really talking about what's driving the epidemic, then you're really not doing favor to the data. And then to talk about the national HIV strategy with the highlight on health equity. To talk about, highlight two of our prevention efforts around the national strategy, then to give some key points for state legislatures, and then a couple of closing remarks. I do want to begin with this quote by Nelson Mandela, which I think is very appropriate when we talk about health inequities. And he says, "I am what I am both as a result of people who respected and helped me, and of those who did not respect me and treated me badly." And that speaks to how we look at individuals, less from a moral perspective, which is not our job, but more to look at the health of individuals and how we can help others, because that's a society kind of perspective. So now, looking at the epidemiology of HIV in the U.S., of course, our data tell us that there are a little over 1 million individuals who are, that's adults and adolescents, who are living with HIV in the United States at the end of 2006. And that is the year for which we have the most current incidence data. In 2008, there were 421,000 persons who were diagnosed with HIV, that's regardless of stage of infection. In the 37 states that had long-term confidential name-based HIV infection reporting, if we look at it according to effects, men who have sex with men in terms of transmission category accounted for the greatest proportion of the estimated number of new infections, and by race, ethnicity, African Americans were more disproportionately impacted than in any other group. So I have a series of slides I'm going to run through fairly quickly that will show this sort of in a pictorial form. I included these slides so that we could look at, and this is diagnosis of HIV among adults and adolescents. Again, these are 2008 data in the 37 states and 5 U.S. dependent areas for which we have the confidential name-based reporting. Males and females, I included it so you could look at the striking difference in the number of cases among males and then those among females. And then you can look at it also around transmission risk. That is, what did these individuals report as their risk for getting HIV? Looking at the male group, we see 72% were due to male-to-male sexual contact, 15% was due to heterosexual contact that's high risk, that's with an individual known to be infected or at high risk of HIV. If we look at what's going on with females, we see that 84% it was heterosexual contact, 15% injection drug use. This slide looks at the diagnosis within individuals who are classified as men who have sex with men, and it's by race, ethnicity. Again, about 22,000, almost 23,000 cases. We're looking at 40% reported their race, ethnicity as Black, African American, 37% as white, and 20% as Hispanic or Latino. This slide looks at, this is a very striking slide. If you look at the age category there, these are 13 to 24-year-olds. Diagnosis of HIV infection, again, among individuals who reported their risk to be men who have sex with men. Look at the rate for African Americans, 63%. Looking at that for whites, 18, 17%, and Hispanic Latinos. This slide looks at the diagnosis with females, and I included this slide to show the difference between the pie chart, I guess, on my right looks at the diagnosis of of HIV infections, and then the pie chart on the left talks about the female populations in those states from which these diagnoses were taken. So if you look at that, you see that 67% of the diagnosis, and again, these are adolescent and adult females, were among African Americans, whereas African American women only represented 14% of the population. 18% were among individuals who reported their race, ethnicity as white, but they made up 70% of the population in those groups. So that shows the stark disparity there. Again, this is just a slide to show diagnosis among adolescents and adults by race, ethnicity. These are for the 2005 to 2008 data. And we can see among black African Americans still the distance there between the other bars that are down lower and the slight increase toward the end there. This is a summary slide. Looking at data from 2005 to 2008, again, 49% of the total were African American, 64% of the women who were diagnosed were African American. In 2008, 50% of the diagnoses were among black African American adults and adolescents. And this slide looks at within African American populations among males was individuals, 64% reported their transmission risk to be male-to-male sexual contact. The women was heterosexual contact. These are individuals living with the diagnosis of HIV. And this was at the end of year 2007. We see, again, 40% male, African American, 37% white, 61% of the females reported their race ethnicity as African American. This slide looks at states, and these are rates of diagnosis. These are 2008 data for the 37 states and 5 U.S. dependent areas, and looking again at the Northeast, and you see the overall rate for the U.S., the total rate is 23.6, but these rates are reported per 100,000 population to take into account the size of the state, so you can really see what's going on. And if you were to look at, I guess, in this region, New Jersey being about 25, that's above the national average. Look at New York, 39.8. This slide looks at rate of AIDS diagnosis. So these are individuals who are diagnosed at the late stage. And again, if we look at New York, let me see some of the other areas coming down. Look at D.C. If you look at the total rate for the U.S. being 12.3, the rate in D.C. is 93.3. Now, if we look at, these are adults and adolescents living with an AIDS diagnosis at the end of 2007. And again, the total rate, look here at the 186.3 for the nation. Look at D.C., 1,781. Taking a look at New York, 456.9. And this is sort of my last slide, I guess, with data to look at the top 10 states by the cumulative AIDS diagnosis and AIDS diagnosis per 100,000 population. And again, you see the district being high there in this slide. So, given that data, let's talk about what's going on, and I think it's most important to talk about contributing factors here. And they're mostly the social determinants of health that we talk about. First of all, as my colleague David will present, the prevalence of other sexually transmitted infections in African American communities and Latino communities is higher than it is in others. So, and you know that your risk of transmitting or acquiring HIV is influenced if you have another STI. And we know that African Americans tend to have sex with other African Americans. So therefore, your chances of encountering an individual who's infected is higher even with lower risk behavior. That is, that an African American woman could have sex with maybe 2 partners, and her risk might be equal to a Caucasian woman who has sex with 15. So it's something like that. And then, of course, the socioeconomic issues. If we look at poverty, we know that there's an association between poverty and health disparities across the board, not just HIV. And look at the numbers in terms of individuals who live in poverty. That speaks to your ability to access health care. It speaks to your educational ability. It speaks to your ability to generate incomes. It speaks to your ability to get decent housing. And all of those things can be a risk for risky behavior in terms of HIV. Discrimination, sexism, racism. Paula Braveman does some great work on how discrimination and racism affects individuals and their HIV risk behavior in terms of individuals not even wanting to go in to get health care for particular reasons, or even not allowed to get adequate housing for those reasons. And some of the others now. I want to speak a little bit about the incarceration rate, because what you see often quoted is that, you know, people are going into jails or the penal system and they're engaged in risky behavior. But our data tell us that individuals are infected when they go into the penal system, and that they're receiving coverage when they're there or being treated when they're there, but then they leave and they don't receive treatment, and they engage in risky behavior. Also, think about the fact the stark numbers of particularly African-American men that are in the penal system, they're pulled out from society where they could have an impact. They're away from families. They're away from their partners. And that's a break in the network there. So all of that contributes to the rates that we see. Also, some of the others, lack of awareness, and you say, of course everyone knows about HIV. Not necessarily. Individuals, we don't talk about it. We don't talk about how to prevent it. So not everybody is aware. They're not aware of their risk behavior. Some of the relationship factors, women being financially dependent on their partners, and there's this sort of imbalance. And we all talk about this in Atlanta, where the ratio, I think, of African-American men to women might be something like 1 to 9, something like that. So you talk about partners availability, sexual and physical violence. I already talked about substance use, your partner's risk, individuals who have older partners that might be risky, that particularly speaks to adolescents, individuals who have a history of childhood sexual abuse, more likely to engage in risky behaviors. And if you have competing priorities, if you're unstably housed, if you cannot feed your children, what are you going to do in order to be able, what's going to be your top priority? That or prevention? I mean, it's a matter of needs. So, given that, for the first time now we have a strategy, a national HIV strategy. It was released in July 2010. It has 3 main goals: to reduce the number of people who become infected, to increase access to care and optimize health outcomes for people who are living with HIV, and then to reduce the HIV-related health disparities. And when we talk about that strategy, some of the key steps for the public and the private sector, and that's us to do, is to work on activities that will reduce mortalities in communities at high risk for HIV, and to adopt more of this community level approach. Instead of focusing on individuals, realizing that individuals engage in risk behaviors in the social and contextual environment in which they live, then we actually need to intervene at a community level. And also to reduce stigma and discrimination around people living with HIV. So what does our agency encourage? We talk about doing things like intensive interventions for HIV-positive individuals, individuals that are very high risk. That gets to the incidence. That gets to new infections. The second one, again, focusing more on the community and the structural interventions, less on an individual level, but more what we can do at a community level and on some of the structural issues that affect individuals' risk. And then talking about this knowledge and getting everybody to talk about it so we can have a supportive environment for the prevention efforts that we do address. We're expanding our reach of services. The second bullet talks about our testing services, expanded initiative. If individuals know their status, there are data that tell us that if an individual is aware of their status, they will do things to protect their partners. And we know that about 1/5 of the people in the U.S. who are infected with HIV are unaware that they're infected. That's a problem, because that means that those individuals are going to be engaging in behaviors that put others at risk. It's about 21%. Okay, we're developing new effective prevention interventions and mobilizing broader community actions. So I wanted to highlight just 2 initiatives that we have. We had recently funded this expanded HIV testing initiative. That speaks to what I just talked about, that 21% of folk who don't know that they're infected. And the goal there was to test 1.5 million people and identify 20,000 new cases. We gave $70 million to health departments in 25 jurisdictions. Now, that's over, but just funded a supplemental funding with a 3-year expansion in 2010 that's going to go to 2013, and that's going to, we had an increase in funding to $36 million. That's in 30 funded jurisdictions that accounted for about 90% of the AIDS diagnosis in the United States. And then our big one that was just funded, that's being called the Demonstration Project for the National Plan. It has this long name that we affectionately call ECHIP, Enhanced Comprehensive, so forth and so on. The goal of that is to facilitate the development of comprehensive plans for HIV that are developed in areas, in the statistical areas, metropolitan statistical areas most affected by HIV. So we're having them do coordinated combination of HIV prevention care and treatment services, and focusing on improving the implementation of prevention care and treatment using interventions, intervention targets, that means the most high-risk populations, and scaling them up to where we need to get them. This talks a little bit about the plans. They should prioritize programs that are scientifically proven to reduce HIV infection, increase access, reduce disparities. They should be able to demonstrate that these can be long-lasting. We want it to be scaled to at a community level, and also it needs to be cost-effective. And they just had the main principal investigators meeting for this project, I think back in early November. So this is ongoing now. And our center just published these white paper on social determinants of health. These are some excellent documents. They're on our website. I would encourage you, if you have an opportunity, to read them, as they talk about how we can intervene on some of the contributing factors to really have an impact on HIV. And then we, of course, these are our evidence-based interventions that are developed for different populations. Willow for women living with HIV. We have the Cuídate that's focused on Hispanic Latino populations. D-Up, Defend Yourself, focused on African American, gay, and bisexual men. Safe in the City is a brief video-based intervention that can be delivered in health clinics. 3MV, Many Men, Many Voices, also focused on MSM. This is Healthy Relationships, which deals with, and there's several, I have them out, RAP, Community Promise, Connect, focuses on couples, and these are just some of our evidence-based interventions. There were two very exciting biomedical interventions that were recently talked about. This microbicide gel for women, and when I say this, the caveat here, of course, is we have years to get this out, but this is exciting to see these results. This gel, microbicide gel containing tenofovir, used by women before and after sex, has been shown to reduce their risk of infection. This was reported at the International AIDS Conference. These data are from trials in Africa. And then we just did a release last week along with NIH on pre-exposure prophylaxis. That is providing the drug Truvada to HIV-negative men who are at high risk for HIV. And findings from the clinical trials have shown that this has actually allowed those men to prevent infection. We have guidelines on our website that, or talk about developing guidelines around PrEP on our website, and all of the specific information is available there. So, getting down to all of that, what can state legislatures do? Support policies and activities that ensure that the prevention funding in your areas are allocated to geographic areas that are consistent with the epidemic. That's what I call the biggest bang for your buck. Put it in high-risk communities, targeted the highest risk populations. That's important, because then you're going to get at the prevalence that we're getting at the high prevalence areas and having an effect on transmission. Also, you can support policies and activities that expand access to effective preventive services. And again, you want to focus on services with the greatest potential for population-level impact, and you're going to target the highest risk populations. That's important. Target your resources to facilitate linkage to care. So how can you do that? Linkage coordinators in settings where at-risk populations receive services. That's described in the national strategy very well. Policies that increase collaboration. So we're talking about integrated services here, where you have medical providers, you have agencies that provide counseling and testing, but a lot of individuals are also in need of mental health assistance, they're in need of substance abuse, they may be unstably housed. So if we can integrate all of those services and have resources targeted toward those areas, it would have a very positive impact. Also, support public health approaches to HIV prevention and care by looking at criminal statutes. In some cases, transmission of HIV there's a law against it, but how are those laws crafted? And do they really take into account transmission risk? Is it based on science? What is it based on? So if you're reviewing those laws, support civil rights laws around housing, around access to care. And David Satcher said in one of his papers on Dr. David Satcher, in one of his papers on social determinants of health, that we should have a focus on health in all of our policies. The last slide Support actions that expand resources to address these social determinants of health. Put resources in areas that will have a positive impact on education for all, on housing, on employment, on racism, on stigma, on discrimination. Support and provide resources to activities that promote HIV testing and linkage to care and prevention services. That gets at individuals who are unaware. And then support programs and adopt policies to get those at a high risk for HIV tested early and often. And you can't see that slide because it's in red, but it says there is hope. And I like to always end with that. But to remember, to turn the tide, we all have to confront the tough issues. Everybody, every action counts. We have to be able to talk about it. I find that, you know, I always say this to my colleagues at CDC, sometimes we can talk about every possible sexual position, every possible anything that's going to get someone, put them at risk for HIV, but when we start to talk about race and we start to talk about the reasons people are disproportionately impacted, the room becomes silent because we're not quite comfortable with that. But when are we going to get comfortable with it? If we can't move beyond that, what are we going to do? And I remember training, I trained as a pharmacist in the 70s when we were talking about venereal infections and venereal diseases. And I remember a sweet mate of mine had recently been diagnosed with HPV, and we didn't know what that was. And she was really being stigmatized. And I remember going to my microbe professor to say, I don't know what this is. This was 1978, and I'm a junior pharmacy student. Can you tell me what it is? And there were 2 women in my class at the time. And he said to me, you know, Miss Hubbard, which is my name then, all you need to do is to give them their probenecid and ampicillin, look in their mouth, make sure they swallow it, make them feel bad because they're nasty, dirty people, and send them out the door. That was the prevalent. So, I mean, wonderful. That started my odyssey on work in public health because I knew he was wrong. And if that's where we start, no wonder we're where we are. That's what I always say. So anyway, break the silence, increase awareness. We got to talk about it. We have to have open and authentic communication about risk with partners. These are all individual things that we can do, and to get tested. And I have to include this very nice slide from my agency that says the findings and conclusions in this presentation are those of the authors and do not necessarily reflect the views of the Centers for Disease Control and Prevention. And then to thank you for your time.